This is Dr. Sandra Johnson. I'm on the glaucoma faculty at the University of Virginia, and I'm going to talk about lens-related glaucoma. Lens-related glaucoma is often related to mature cataracts, as the one you see depicted here. This is also a mature cataract. This is a Morgagnian cataract, where the cortex is liquefied and the nucleus has shrank and is suspended by gravity in the liquefied lens material. And this is found on the Root Atlas, which is a handy internet reference. So when you have one of the lens-related glaucomas called phacolytic, you can say, well, this sounds like melanocytic and hemolytic. And so what do all these three glaucomas have in common? And it's actually macrophages. You know, macrophages are cells in our body that engulf things, and in the case of phacolytic glaucoma, they're engulfing lens material, and hemolytic, it's blood material, and in melanocytic, it's melanin. And you can see here in this mature cataract, like the ones I showed you before, there's a steamy cornea, the eye is red, and there's a type of hypopyon here related to the phacolytic glaucoma. So what is the pathogenesis of phacolytic glaucoma? It's actually leakage of lens proteins, more so the high molecular weight proteins that come into the anterior chamber, and then the macrophages, as I mentioned, come and engulf the protein, and then this causes obstruction of the trabecular meshwork. The presentation is much like the eye that I showed you. It's red, the vision can be worse than normal, and there's pain. It's often an elderly patient who has long-standing cataract. That way it becomes mature. The pressure's high, the cornea is steamy and edematous. If the gonio shows visibility, the angle is open. And there's cellular reaction in the anterior chamber, possibly the hypopyon as I showed you, and no charatic precipitates. So what is the treatment for this particular lens glaucoma? The treatment of phacolytic is some steroids, because of course that will help with the massive inflammation. Some medications to try and help the markedly elevated pressure, but really it's the prompt cataract surgery that will be most effective for the patient. And this is a patient who presented with phacolytic glaucoma with a steamy cornea and a white mature lens, very high pressure up to 49. And one day after surgery, the pressure was already down to 8 and has not been elevated since. There's some series in the literature, mainly from more developing countries than from Western countries, since they see more mature cataracts. In one series of 135 cases from India, they looked at a retrospective analysis. And they looked at patients who had phacolytic glaucoma that were treated with a cataract extraction alone versus a combined procedure. And they had chosen combined procedure for the eyes with over 7 days of symptoms, and of course had poor control with medications. And the cataract alone group had 1 to 2 medications needed for the first 2 weeks, but after that there was essentially no change or difference between the two groups, suggesting that cataract alone is a good procedure for phacolytic glaucoma. Here's another case of a lens-related glaucoma. This one is a 9-year-old, aphakic from a congenital cataract surgery at age 3, long-standing glaucoma but well controlled on Zalatan, and who went to his primary eye care with intraocular inflammation and uncontrolled pressures going in the 30s, despite taking him off and on the Zalatan and adding 3 aqueous suppressants. So this is a schematic of what his exam looked like, and compared to a prior exam he had, there was now white fluffy material behind the pupil. He did not dilate very well and only had about 5 millimeters of dilation. He did have some cell and flare, but no charatic precipitates. So now we have to think, what is the diagnosis of this glaucoma and how are we going to manage it? So this really was a lens particle glaucoma. This is something that was described as early as 1900 and named lens particle glaucoma about 1955. This particular boy was referred for a vitrectomy, where that lens material behind the iris was removed, and his pressure went back down to 17, and he actually no longer required the Zalatan. And the pathophysiology of this is usually liberated cortical material. It can be seen on slit lamp or perhaps gonioscopy, and the material blocks the trabecular outflow, much like the lens proteins in phacolytic. And the treatment, just like in phacolytic, is remove the lens materials. There are some patients who will do fine just with steroids. And here's an old paper on this particular problem, and you can see that this patient had fluffy white lens material, much like the boy that was presented. And he had an anterior chamber aspirate, this particular patient, and there were some macrophages engulfing this cortical material. And this was a paper from Korea. So, precursors of lens particle glaucoma. A big thing you have to note is down here in yellow is that these eyes have a capsule that is not intact. Phacolytic has some macrophages. It's related to lens proteins, but it's an intact capsule. Lens particle glaucoma, the capsule is not intact. So you can have changes in the lens capsule from trauma or where it's been perforated. YAG capsulotomy can result in lens particle release. After a cataract surgery, there can be lens material. You can have delayed onset, and those are the ones that have macrophages. You can also have, like my boy, I want to say, that had the delayed onset because it was, 6 years after his cataract surgery. Here's another case. This is number 3 for lens particle glaucoma. This is a 35-year-old male that was hit with a nail. He had his corneal laceration repaired, and there was suspicion at the repair that his lens capsule had been ruptured as well, and the lens was immediately white. One day after his repair, his pressure was up, and he was put on COSOPT and bromonidine. However, 3 weeks later, pressure went up to 45, despite this maximal medication. Let's back up a little bit and look at some of the research on obstruction of aqueous outflow. This is a study from 1978 from Dave Epstein and his mentor Morton Grant, and they looked at outflow of enucleated eyes when they perfused them with lens particles and lens proteins. They took eyes that were 48 hours post-mortem, and then they set up an inflow-outflow apparatus to measure outflow at a pressure of 25. And then they perfused these eyes with different lens particles, high molecular weight, low molecular weight, and they also tried to look at the effect of washout, just rinsing out the anterior chamber. And they found that there was a significant decrease in the outflow when you had a lens homogenate, which just means, various lens proteins, in the high molecular weight proteins specifically. If they had only low molecular weight proteins, there wasn't problems with the outflow. And the more duration of time that these higher molecular weight proteins were in the anterior chamber and going through the trabecular meshwork, the more resistance to flow there was. And they couldn't reverse the flow by using alpha-chymotrypsin, which digests zonules, or by just washing the chamber out with balanced salt solution or PBS. And this just shows you the control eyes. And the control eyes, of course, had stable flow, okay? But once they added high molecular weight proteins in lens homogenate, they had less and less outflow. And even though they put in alpha-chymotrypsin, they did not get any restoration of the flow. And this is similar data right here. Just showing you lens-soluble proteins on the graft on the left and irrigated and no change in the decreased resistance. and the graph on the right is the lens soluble proteins or high molecular weight, and again, same results. So just rinsing the chamber doesn't affect it. We really have to take out the source of the proteins, which is the entire lens. So lens particle glaucoma can be days or weeks. You know, if you think of the child that I presented first, it took him 6 years to get lens particle glaucoma. If we talk about the trauma patient, it took him several weeks. And the range has been anywhere from 2 to 65 years after congenital cataract removal, and that's probably because you need time for the proteins to denature and become more heavy molecular weight ones. And it's rarely associated with YAG capsulotomy, which I mentioned, and those are the eyes that are more likely to be controlled on a low-dose steroid. Here's a pathology slide that I came across, and you can see where the arrow's pointing all this proteinaceous material deposited in the angle, along the iris, behind the iris, near the lens. And so this is what's clogging up the molecular meshwork, trabecular meshwork, as well as the macrophage that is trying to engulf it. Here's a higher mag of the same thing, and showing you where these little black arrows are, all this proteinaceous material in the angle. So the epidemiology, you know, as you can imagine, since it can happen with congenital cataracts, it's from infants to elderly. And there is a blip, like in the other patient I showed you, between, say, 20 and 40 due to trauma. And it really doesn't matter your race or your sex. You have the same problems with this, given the same scenario. Okay, clinical history, it can be asymptomatic, but it can also have features of very high pressure, you know, like an angle closure or a phacolytic patient. And there, of course, has to be a history of cataract surgery or some kind of trauma to the lens. And it can happen as well with posterior dislocated lens fragments, because that can have cortical material and lens proteins that come forward as well. Here's a picture of the eye that I mentioned with trauma, and you can see down here that there's a rent in the anterior capsule, and you can see some of this lens material that's been liberated, and this led to elevated high pressure. That patient was given some Diamox. His pressure went down from 45 to 38, and then he had a prompt cataract surgery that actually was done with the anterior vitrector. And he's somebody that perhaps could have been referred to a retina service, because we didn't know it, but he also had a posterior capsule rent, but we did not drop any of his lens material. Pressure was still a little high at 1 day post-op. His pressure went down to 11 by 1 month, and his post-op was stopped, and actually his pressure normalized since then. All right, moving on to another lens-related glaucoma where there is an open angle, and that would be PHACOANAPHYLAXIS. And this is a very rare and a much more serious disease where there's a zonal granulomatous reaction, and they make KP. And it's a loss tolerance to lens proteins. And you can see from my little box here, just about every type of inflammatory cell is involved in this reaction. And type 2, 3, and 4 hypersensitivity reactions have been involved. So it's a pretty global inflammatory reaction to lens proteins. One etiology can be drop nucleus, just like that can cause lens particle. You know, in that situation, the patient really needs a PPV, you know, a vitrectomy to clean that out. The presentation can look like sympathetic ophthalmia, it can look like endophthalmitis, it can look like toxic uveitis, because they all often have KP as well. And you can see this B scan shows you a drop nucleus. You can see the groove in the nucleus, which is kind of cool, and you can see some vitreous hemorrhage as well. So this is a patient at risk for both phacoanaphylaxis and lens particle glaucoma. There's a global term called phacogenic or lens-induced uveitis that's been proposed. And this particular term just encompasses the spectrum of uveitis caused by the lens, where the definitive treatment is lens removal. So this can include the phacoanaphylactic, the phacolytic, and the lens particle patients. And I want to mention that some of the phacoanaphylaxis patients, because it's so inflammatory, actually have hypotony instead of glaucoma. So that can also present with a low pressure. And going back to phacogenic, the idea is that our response to the lens is related to our individual genetic makeup, and that some of us get a lens-related uveitis that needs lens removal. And this is just schematics for you. This top left shows you a hypermature cataract. And to the right, you see a B scan in this individual because there's no view of the posterior segment, so they can look at the retina with a B scan. And you can see the lens is so big, we can see the actual thick cataract on the B scan. And of course, any white lens like this needs to have vision blue to most safely do the capsulorhexis and proceed with the case. So that brings me to PHACOMORPHIC glaucoma. So just like a white cataract, as we started this lecture, could lead to an open-angle secondary glaucoma, a white cataract can also lead to a secondary angle closure glaucoma. So the mature lens suddenly becomes intumescent, and the patient presents just like they have angle closure. And traditionally, these are eyes not prone to angle closure before this attack. It's related to the lens. The different ways to approach this: it's been proposed to treat the pupillary block first with an iridotomy, or if they have one that you don't think is open. Some people advocate gonioplasty, and there's been one paper that showed 21 eyes that had 80% IOP control before they went on to cataract surgery, and another paper showed 10 eyes with similar results, with some stabilization before the cataract surgery. And really the definitive treatment is removal of the lens. And here's a Visanti anterior segment OCT showing a nice big cataract. And you can see how shallow and compromised the anterior chamber is. This right here, this white, is the iris, and this patient has phacomorphic angle closure. There's been some case series also from developing countries like India, where they looked at what kind of glaucomas result from their mature cataracts, and they found that 1.5% of 27,000 cataracts had a lens-related glaucoma. 72% were phacomorphic and 28% were phacolytic. And as I mentioned before, phacoanaphylaxis is very rare, and they didn't have any. And about 80% had pressures over 30 on presentation, and about 80% had their IOP normalized on discharge. So you can tell from this series that phacomorphic is probably more common than having phacoanaphylactic glaucoma from a mature cataract. And I'll just move this, you can see the reference. So now, what about cataract surgery and angle closure? Right, that's a popular topic in this day and age. And this one particular study by Jacoby looked at 43 eyes treated by cataract surgery versus just having an iridectomy when they had cataract and angle closure. And they followed them for 10 months. And the ones who had their lens removed required less meds and less further procedures. And then actually 11 patients of the 32 went into good control and had cataract surgery. So we all know, of course, that cataract surgery does increase our anterior chamber depth, and it does change the relationship between the iris and the lens. You know, it lets the lens fall back away from the iris, takes the posterior pressure off the iris when there's a thin intraocular lens in place rather than a thick cataract. What about creeping angle closure? That's another entity in these eyes that are small eyes. So unlike the ones that have a normal eye, like the PHACOMORPHIC, people who are a bit small and prone to angle closure in the first place can develop creeping angle closure and go on to chronic angle closure. And that's because their chamber progressively shallows more and more as their AP diameter of the lens increases. And sometimes by the time they present, it's hard to distinguish them from a PHACOMORPHIC eye. So when you have patients that have cataract, right, so this patient obviously has some nuclear sclerosis, pretty shallow looking chamber despite a patent LPI. These are the patients that their gonioscopy needs to be followed so that it's caught early if they're developing PAS. And here's the same patient with a much deeper chamber once they have replaced their nuclear sclerotic lens with a pseudophakic lens. And, you know, things to remember when you measure patients, a normal ACD is about 2.8, and once you go under 2.5, you're at risk for angle closure. Angle closure, if a patient does go into that, does cause loss of endothelial cells, and of course are more at risk for further loss of endothelial cells the more shallow the chamber is when they get to their cataract extraction. And this is also the group that can develop aqueous misdirection, which is a totally different lecture topic, but something you should be aware of. Here's an 80-year-old female with acute elevation of her pressure, right? So she has a history of an LPI, and actually twice, a 20/60 cataract, but you can see it's a pretty significant nuclear sclerotic cataract. Sees pretty well out of it, so it's never been removed. She has a shallow ACD. She was actually initially treated with iridoplasty, and from there went on to have cataract surgery. And she went from maximum medicines, including Diamox, to 20/20 vision and a nice deep chamber once that lens was removed. And you can see here one of her iridotomies from prior. So she was an eye prone to angle closure because she had iridotomies twice, who developed a kind of a PHACOMORPHIC angle closure on top of that. Here's another patient. You can see when you look at the slit beam, very shallow chamber. She's had an iridotomy. She had gonioplasty. She had a very cloudy cornea from her attack of angle closure. You can't see it in this slit lamp photo, but she had 4+ brunescent nuclear sclerosis, and that was removed by an extra cap. And despite taking her lens out, she never recovered good vision because she had waited over a week to present with her very high eye pressure. All right, other lens-related glaucomas. You can see here in this histology slide that their lens is actually very anterior, very much like in this clinical picture. Right, so what do we have here? We have a dislocated lens, and how are we going to manage this? Right, so you can have pupillary block from these types of dislocated lenses. It can be called ectopia lentis, right, and that can be related to syphilis, Marfan's, high myopia, pseudoexfoliation, very mature cataracts. There's a lot of etiologies. Can be from trauma as well. And the whole lens can sublux into the anterior chamber like the clinical picture I just showed you. And a patient can have recurrent attacks of block that'll give them PAS in their angle, give them episodic high pressures that damage the discs and get corneal injury. And treatments are iridotomy, so that, and you have to do multiple because you don't know where the lens is going to be blocking behind the iris when it moves about. Miotics to keep it behind the iris, and of course removal of the lens removes the subluxation. So here's a gentleman who presented He came to the glaucoma clinic because he had had iridotomies and acute angle closure in his right eye. And years later, after his trauma, as his cataract matured and was very loose from the trauma, you can see here where it's bad zonules, he went into angle closure and was treated by iridotomy and had no further angle closure. So this lens was actually removed by a pars plana vitrectomy. We put in an ACIOL. He came back from hand motions to 20/20, and his angles completely opened, and he's had no further glaucoma. So this man had his acute angle closure from his subluxed lens. Here's another patient who had a type of congenital cataract. He's blind in the other eye, and he's had iridotomies. He's got one here, and he actually has one over here because his lens moves about, and he still sees 20/50 and will someday have also a vitrectomy. Here's a condition associated with subluxing lenses, but in this case, wheel Marcassani, you don't want to use myotics unless the zonules are completely gone, because the myotics make it worse. You want to have them on a cycloplegic because it's a small spherical type lens. Let's speak a few minutes about glaucoma related to an artificial lens. Right? We see these all the time. This eye is dilated and has a artificial lens within it, and you can see that the capsule is also open. And things that we think about when we're talking about glaucoma related to an implant can be pupillary block. You can have a uveitis glaucoma hyphema syndrome that gives you glaucoma. You can get a pigmentary dispersion syndrome that leads to glaucoma. Here's a case of a patient who had cataract surgery. I showed you his picture. He had an open capsule, and he had this sullen flare and was sent first to a uveitis specialist who didn't find an etiology. He then went to a retina specialist because he had some vitreous heme. So you can see here where, and then he came to a glaucoma specialist because he had high pressure. So he actually had UGG, right, uveitis, and then he had hyphema, except it went in the vitreous because his capsule was open, and he had glaucoma. So he had an UGG syndrome, right? So, you know, we had to look further at his exam and figure out what was going on here. So his capsule was open, and in an interview with the patient, he never had a YAG capsulotomy. Looking at the lens, it was an acrosoft. It was in the self, and it was a little bit tilted, right? And this is a lens that's only indicated to be in the bag. He had TIDs in the nasal iris where the lens was tilted towards, and he had a lot of pigment in his angle. So actually, he had UGG, but he also had a secondary pigmentary glaucoma. And so this kind of glaucoma has been reported with piggyback lenses, as well as the acrosoft lenses in the sulcus. And an IOL exchange often fixes the problem. You know, some have responded to trabeculoplasties. You could try myotics to stabilize the iris. But this patient actually did well with the IOL exchange and didn't require any further glaucoma medications once he had an appropriate lens in his sulcus. Here's another patient, you know, with more just the pigmentary glaucoma. You can see here that this patient has a multifocal lens, but actually the refraction didn't come out quite right, and her ophthalmologist put a piggyback IOL in her eye as well. So now she had a lot of lens, one in the bag and one in the sulcus, and then one in the sulcus started to cause iris chafing. So she had transillumination defects. She did not have erosion into the iris or ciliary body, but that's what gives you hyphema often. And of course, if an eye is very inflamed, they can get iris neovascularization. And then this arrow here points to that circle of pigment that she has that's been heaped up pretty much over her pupil and giving her blur and exacerbating her glaucoma.